So I think we're going to start. So good afternoon, everyone. Today, I would like to first thank you for being here. My name is Sophie Reyes, and I am the Marketing Director at Best Buy Medical, and I'm very happy to be your host. Today's webinar is presented in partnership with Hollister. During this session, we will talk about optimizing bladder management through intermittent catheterization. We will review the clinical use of intermittent catheterization, best practice guidelines, and the different types of catheter used in practice. Now, I will pass it over to Tariq Alam, Senior Manager, Clinical Affairs at Hollister. I wish you a very good webinar. Tariq, please go ahead.
Thank you very much, Sophie. A huge thank you to Best Buy for this webinar opportunity. Hollister is a company specializing in healthcare products, including ostomy, continence, and critical care products. It operates globally and sells its products in nearly 80 countries. Hollister opened its Canadian office in 1959, and our mission is to make life more rewarding and dignified for the people who use our products and services. I'm thrilled to announce our speaker, Corey Knott, a nurse continence advisor. Corey has worked in urology since 1999, where she began working at the University Hospital in British Columbia. She completed her nurse continence advisor diploma from McMaster University. She currently practices at Richmond Urological Care Centre, where they specialize in pediatric and adult urology, urological oncology, with a subspecialty in male and female reconstructive surgery. Her expertise includes advanced urodynamics, clinical education, and mentoring of advanced practice nurses. As a disclosure, Corey's been supported to present this webinar, and the educational material presented here is intended for informational and educational purposes only, and it's not a substitute for professional medical advice, diagnosis, or treatment. Attendees are encouraged to consult with qualified healthcare professionals regarding any medical questions or concerns. Never disregard professional medical advice or delay seeking it because of something presented in this session. Always refer to the product's instructions for use for information on the product description, indications, intended use, contraindications, and precautions. Before we start, we've got a poll question for you. And the question is, what area in Canada are you from? Well, the polls are coming in. A strong lead from Eastern Canada, with some votes coming in from Central and Western Canada. We do have some representation in Atlantic Canada too. Well, with that, thanks everyone for joining, and it now gives me a pleasure to pass it to Corey Knott. Corey, take it away.
Thanks very much for the kind introduction. Welcome everybody. It is my great pleasure to speak with you today on management of intermittent catheterization. Our learning objectives for today will discuss the clinical rationale for intermittent catheterization, provide different types of catheters, and we're going to review best practice recommendations and guidelines in Canada. We will also discuss anatomy and physiology of the urinary system, discuss complications and indications for intermittent catheterization, some tips on how to perform intermittent catheterization, and review the clinical evidence. Next. So the urinary system is made up of two parts, the upper urinary tracts, which have bilateral or right and left kidneys. The kidneys then drain urine down through the ureters to the lower urinary tract into the bladder. At the base of the bladder, or the trigone of the bladder, there are two little slits called the ureteric orifices, where urine drains from the ureters into the bladder and then out through the urethra into the toilet or receptacle. Males also have a prostate, and we will review the location of the prostate in a later slide. Next. The urinary system is quite complex. The kidneys, which we have two of, they filter blood and produce urine, which is waste. Once the urine travels down from the bilateral kidneys into the ureters, from the ureters into the bladder, it enters the bladder. The bladder simply has three main jobs, and that is to fill with urine, store the urine for some time, and then empty to completion. Once the bladder is full, it should send a message to our brain that it's time to go to the bathroom. So once we get to the toilet or the urinal, our brain sends a signal to the bladder. The bladder muscle should contract in a sustained pressure and empty to completion. The process of urination is actually complex. It requires an intact nervous system and brain cognition. Once the brain sends a signal to the bladder to contract, the internal urinary sphincter needs to relax and open so the urine can leave the bladder through the urethra. The pelvic floor muscle, the Kegel muscle, should relax, and the bladder should empty to completion. I will point out that the nervous system is comprised of the central nervous system, which has the brain and spinal cord, and the peripheral nervous system, which takes all of the information from the brain and the spinal cord to the peripheral nerves, such as our organs and our limbs. Next. The female urethra is approximately 3 to 4 centimeters in length with a diameter of 6 to 8 millimeters. The urethra ends in the perineum between the clitoris and the vagina. And the female urethra carries urine outside of the body. As women mature in life, they go through hormonal changes with a decline in estrogen. This decline in estrogen can affect bladder function. Women can experience urinary urgency, frequency, increased urinary tract infections, and urethral atrophic changes. All of these changes have been named the genitourinary syndrome of menopause. I will also point out that both males and females have a pelvic floor. This is the Kegel muscle. This is the muscle that needs strengthening to control holding our urine in. When we cough, laugh, or sneeze, we engage our pelvic floor so that we don't experience stress urinary incontinence. It plays a crucial role in supporting our visceral organs and maintaining our continence, and also aid in bowel movements. Next. The male urethra is a fibromuscular tube, approximately 18 to 20 centimeters, so it's quite a bit longer than the female urethra, and 7 to 10 millimeters in diameter. The urethra carries both semen and urine from the ejaculatory ducts and or bladder, extending through the bladder neck out the tip of the penis. The urethra, the male urethra, is divided into 3 parts. The prostatic urethra, where we see label 1 there, that's the prostate just outside of the bladder. The membranous urethra, and the penile urethra, which contains the bulbar and pendulous urethra. Next. Sophie, is there any questions before we move on to the poll question?
I don't know. If someone has any question, you can just write them in the question mark box on the right of the screen. So
yeah.
At the moment we have.
Okay,
Sorry?
I'm happy to answer questions as we go. It might be a natural way to tease out questions. Okay,
At the moment we don't have.
Okay, we have a poll question. Can anyone tell us the normal capacity of the bladder? Okay, I think the poll is in. A little bit of changing in the people's decisions. Okay, for any of you that said 3 to 500, you're correct. That's not to say the bladder can't hold more than that, but the recommended volume is somewhere between 3 and 500. The bladder is meant to temporarily store urine at capacity. it is not meant to hold urine in perpetuity. So if a person is well hydrated, you should go to the washroom on average during the day, approximately every 3 to 4 hours. There are people that can hold their bladder for 6 or 8 hours. They make excellent road trip travel partners, but for their bladder function and health, we recommend urinating about every 3 to 4 hours. The bladder should empty to completion with approximate residual somewhere between 30 and 50 mils. The bladder never empties to 0. And in older adults, we will accept a residual of 100 mils. However, I will point out that if a person is experiencing recurrent urinary tract infections or have some hydronephrosis, that's a swelling of the kidneys, on ultrasound or CT scan, or on blood work, they have a renal decline, we will then examine their post-void residual and then implement treatment as necessary. Next. So why do we teach someone to self-catheterize? There are a number of reasons. For instance, if someone has injury to their spinal cord, such as a spinal cord injury through an accident, neurological disease such as multiple sclerosis, Parkinson's disease, or if somebody has experienced a stroke, BPH, which is an enlargement, a benign enlargement of the prostate. That's where the prostate enlarges. I showed you in an earlier slide where the prostate lies outside of the bladder. So you can imagine as the prostate grows, it can block the outflow tract. We call that bladder outlet obstruction. The prostate is somewhat like a donut. The urethra runs through the middle of the donut, and it can grow out on itself and in on itself, and it constrict the urethra, causing some back pressure and the bladder to not empty as efficiently as it should. If a person has experienced a urethral stricture or a scarring somewhere in that urethra, you saw how long the male urethra is, and it's common for a male to experience a scar throughout there. So if there's a scar there, somebody might learn to self-catheterize. There are times when the bladder itself stops functioning. It can become hypotonic or atonic. A hypotonic bladder is a bladder that can squeeze somewhat, but not enough to empty to completion. So it can squeeze, but it loses its power partway through, and then they can have an elevated residual. An atonic bladder is a bladder that has lost all ability to squeeze and generate power. For lack of a better example, it's almost like a floppy balloon. It can just hold the urine like a vessel, but then can no longer squeeze and generate power to empty the urine. Lastly, we have a condition called DOIC. This is where the bladder becomes underactive and overactive at the same time. So the overactivity will occur when a person is at work, in the car, on the golf course, sitting in a movie. Their bladder will send a signal to them to have to urinate at a time where there's no bathroom accessible. And then when they do head to the bathroom, that bladder will not generate enough power or any power to empty. So this can be hard to treat because you can't treat the overactivity because it exacerbates the underactivity. So this is a bladder that has a dual overactive, underactive difficulty. Next. There are many benefits to intermittent catheterization, the preservation of both bladder and renal function, the kidney function, reduce the risk of stones, urinary sepsis, such as urinary tract infection or pyelonephritis, an infection up in the upper tracts of the kidneys, to improve the overall health of the bladder because the bladder is muscle. We need to keep it healthy and improve a patient's quality of life. Next. There are some risks associated with intermittent catheterization. Firstly, urinary tract infection. There can also be a little bit of urethral trauma or bleeding when the catheter is placed. The urethra tissue is similar tissue to the inside of our cheek or on the top of our mouth. So if you ever eat a crusty baguette or something hard, potato chips, it can scratch that tissue and cause some bleeding. The bleeding, although is unsightly to the patient or the client, it is typically not dangerous. A false passage can be created. That is where a catheter can have been placed or is placed, and it makes like a dead end or a fork in the road, if you will. So when the person goes to put the catheter into the bladder, it deviates to this false passage or the dead end, and then they can't place the catheter. Again, a urethral stricture or a scarring in the urethra causes the bladder to not empty efficiently, or a meatal stenosis, which can be a narrowing or a scar, and that's typically at the front of the penile tip. It occurs mostly in men. Next. In Canada, there are two main categories of catheters. Firstly, the uncoated catheter. It comes in both a male and female catheter. This catheter requires a sterile lubricant, water-soluble lubricant, to be added to the catheter prior to insertion. The second category is a hydrophilic coated catheter. This catheter comes ready to use. It comes with a nice coating that just helps slide the catheter in. They can have it with a gel packet or a little water sachet that can be depressed and wet or activate the catheter. And hydrophilic coated catheters come in both female and male lengths. Next. There are different lengths of catheter. There's a regular length, and I'm going to talk on the next slide about the actual size of the catheters, but there's a regular length. There is a compact length, which is often for female patients. They are used for discretion, for portability, and they can nicely fit into your pocket. And so you can carry the catheter around without having someone know exactly what your catheter is. Lastly, there is a closed system. This is a hydrophilic coated catheter. It's a one-piece catheter system. It's a closed system. This is very useful for somebody in a wheelchair or a person who does not have access to a toilet. The catheter can be placed into the bladder. The urine is then contained or caught into a closed bag, and they can empty their bladder to completion, and then they can discard the urine at a time when it's convenient. Next. So catheter sizing and lengths. Generally, the healthcare professional should make a recommendation on the diameter and length of catheter. The catheters are measured in Charrier or French. A little bit of interesting tidbit. The catheter sizing was invented or developed by a Monsieur Charrier in 1842. He was a Swiss-born French gentleman who lived in Paris, and he developed the sizing. In North America, catheters will be called 12 or 14 French, and in Europe, in French-speaking countries, they will use the term Charrier. 1 millimeter size equals 3 French or Charrier. The most common size for a male is 40 centimeters, and for a female, it's 20. But in the compact versions, the compact version can be anywhere from 6 to 8 centimeters in length. For the sizing, typically a pediatric patient would use somewhere between a 6 and 8 French catheter. That's not to say an adolescent patient wouldn't use something a little larger, perhaps a 10, depending on the size of the child. A female would use a 12 to 14 Charrier French, and a male patient would use 14 to 16. If a person is catheterizing for stricture stabilization or dilation of the urethra, there are times where the healthcare professional will increase the Charrier size to an 18 or 20. That's used to help dilate the stricture or the scar so it can stabilize in a round cylindrical shape, and then the catheter is placed every day so that the scar doesn't reform upon itself. Next. There are four main catheter tips. The first and most common tip is the Nelaton tip. It's straight with a nice beveled end. Secondly, and third is the Tiemann or Coude tip. This has a little bend at the end. These two catheters can be used to navigate past an enlarged prostate, a stricture, a sphincter that is spastic. There is some special considerations when having a person use the Coude or Tiemann or olive tip. The tip must be pointed to the nose at all times when it's going into the bladder. So I always say to everybody, remember, tip to the nose, tip up. There is a notch on the end of the funnel end of the catheter that coordinates to the tip going up. So as long as the funnel and the notch are parallel to the person's nose, they can assure that when they put the catheter in, the tip is up into the bladder. Lastly, there is a round or flexible tip. This has a nice tip that can also help navigate a spastic urethra or a enlarged prostate. Next. There are generally two eyelets on the end of the catheter. This helps drain the urine from the bladder out of the catheter into the toilet or receptacle. These eyelets, it's recommended that these eyelets are smooth, which helps increase comfort for the patient, decreases bleeding or trauma, and is easier when the catheter is removed from the bladder. Next. Hand washing is so important for patients. I encourage people to hand wash before and after each catheterization. I teach self-catheterization regularly. I give the example. Imagine you are cutting jalapenos or garlic, and then you need to put contacts in your eyes. I want you to wash your hands so that you could wash all that hot spiciness away before you put it in your contacts. So I want them to wash their hands well on all sides prior and after catheterization. For pericare, cleansing with some mild soap, something that is gentle, is recommended, or they can just use plain water. Once daily is recommended. However, if somebody feels that they have become soiled or they're, say, out for a run and they're sweaty, they can, by all means, wash prior to each catheterization. A clean workspace is necessary, so getting the person to cleanse with some kind of antiseptic wipe prior to putting their supplies down is necessary. To have good lighting and also enough time. There is nothing worse than someone being rushed when they're trying to perform catheterization. At the beginning, they're feeling a little bit nervous about this procedure or this task, and I always encourage people to leave enough time so that they can take their time and feel confident about performing catheterization. Next. For females, there are a number of ways that a female can insert the catheter. Often we recommend standing in front of a toilet. However, if the patient or the person has mobility concerns or balance concerns, we would not have them stand in front of the toilet because, of course, we don't want them to be a falls risk. Typically, they'll put their foot on the toilet seat or on a little stool beside the toilet. This will help isolate the urethra, and so the catheter can be placed. Alternatively, they can sit on the toilet, either facing the toilet backwards or facing frontwards, and then catheterize. The catheter is typically held in the dominant hand, much like you would hold a pencil. And then the non-dominant hand needs to open both the labia majora and the labia minora, the inner and outer labia, wide enough that the catheter can be easily inserted into the urethra. And we have a nice diagram at the top of the screen. There are also tools that can aid in catheterization for females. A leg spreader can be used, a mirror, which can help visualize the urethra, a light, which can be put towards the urethra, and so that the urethra can be visualized. Also, extension tubing can be added to the catheter so that it can easily empty into the toilet or receptacle. Next. For males, they can also face the toilet standing up. But again, if you're concerned about balance or mobility, we would encourage that person to sit either in a chair or a wheelchair in front of the toilet. The non-dominant hand typically holds the penis sort of tight away from them. We sort of get them to stretch their penis slightly just to elongate the penile urethra, and the dominant hand inserts the catheter into the bladder. There are also some helpful tools that can be utilized. A pant holder, so if they're in a chair, you can get a holder that will hold the pants in place, a gripper for the catheter, or a device to hold and support the penis. Next. It is very important that the client-patient catheterizes frequently and regularly throughout the day. We advise to not miss your catheterization, but keep on a schedule. The healthcare professional should provide recommendations about how frequently a person will catheterize. We base those frequency recommendations on urine that is left behind in the bladder. And so typically we do not want any more than 400 to 500 mils to be drained from the catheter at one time. We want to preserve renal function and kidney health and bladder health. If a person is able to urinate independently, volitionally on their own, we would have them void prior to catheterization, and then once they void, they can then place the catheter into their bladder, and we ask that they measure and record the residual volume, the post-void residual, so that we can ensure that their residual volume isn't at a too high of a level. Next. Are there any questions, Sophie?
No questions, Corey.
Okay.
No.
Okay. The third and final poll question is, do your catheter or do your customers ever reuse their intermittent catheters, either washing or disinfecting them between use? Okay, I think the poll's in. So sometimes 40%, I don't know, 24, and no, and yes, 23. Okay. So for the guidelines in Canada, these two articles were published in the spring of 2020. These are evidence-based guidelines that provide recommendations for healthcare decision-making, and these guidelines are based on review of clinical evidence and research. These guidelines are beneficial to healthcare providers. They help guide decision-making and standardize care for better patient outcomes. In the guidelines, they state that a hydrophilic coated catheter is recommended. It can produce an easier or more comfortable catheterization, less bleeding or microscopic hematuria, and fewer epithelial cells on the removed catheter. It's also more comfortable to use a hydrophilic coated catheter, and it can enhance their quality of life. Health Canada also states that healthcare equipment that is labeled as single use should not be repurposed or reused. There's also a statement that any healthcare equipment that is labeled by the manufacturer as single use should not be recommended for reuse, as it opens up the healthcare provider to professional practice liability. And so really, we recommend single-use catheters only, and this is the standard in Canada. Next. So in Canada, unfortunately, catheters are not covered under the MSP plan. We are trying desperately to get them covered. The only province that covers it is the great province of Alberta. We're so proud of Alberta. They have coverage. We are trying to work towards getting coverage across Canada. There are benefit programs throughout Canada. For instance, Saskatchewan has a para program that will cover catheters for people with mobility aids or devices. The Ministry of Social Development and Poverty Reduction may cover up to 6 catheters per day in most provinces. There's also other ways you can get the catheters covered. Unfortunately, if you have an auto accident, motor vehicle accident, they're typically covered under your motor vehicle plan, workers' compensation if you've had an accident at work, or private third-party medical insurance. Sun Life, Blue Cross, any of those will typically cover intermittent catheters. It is helpful for these programs if the healthcare provider can write a letter to support the use and the necessity for the catheters. Generally, we say talk about which kind of catheter, coated or uncoated, the Charrier or French size, and the length of catheter, and how frequently that person should be catheterizing daily. Next. So to wrap up, our learning objectives that we covered today is we discussed the clinical rationale for why we would perform intermittent catheterization, provided an overview of different types, the Charrier French sizes, the lengths, the coatings of the catheters, and we reviewed the clinical evidence and best practice guidelines in Canada.
Corey, excuse me,
Yes.
we have a question in the chat.
Yes.
So what are your 2-3 suggestions for traveling for a person who performs intermittent catheterization?
Perfect. Excellent question. So if you're traveling, we always say take enough supplies in your carry-on luggage. Okay, you do not want to check all your catheter supplies. If possible, take it all in your carry-on luggage, but if you can't, split, you know, the catheters in the hand luggage and the check luggage. It is recommended, and it's actually easier if somebody uses a hydrophilic coated catheter, especially if they're going into an airplane bathroom. They're very tiny. Hand washing is not always the easiest. So if they can use a catheter that already comes coated, it would make catheterization much easier. If there's a catheter that has a tip and sleeve or some other features that can help with a no-touch system, that would be recommended. And keep on your schedule. That's another thing. Try, you know, if you're doing a long-haul flight to Asia or Europe, you know, make sure that you're sticking on your schedule, catheterizing every, 3 to 4 hours to ensure that the bladder is cycling and emptying on your normal schedule.
Thank you very much. You can continue.
Thanks so much, Corey, for that outstanding presentation. And I agree that, reimbursement for intermittent catheterization remains to be a challenge in some areas across Canada, but there are initiatives in progress by organizations to increase funding and to allow for greater access for intermittent catheterization. Just a little bit about some Hollister products that are intermittent catheters. Hollister does feature some hydrophilic intermittent catheters, such as the Vapro catheter, which provides 100% no-touch protection. It features a protective tip and sleeve, and essentially, a person can hold this catheter without contaminating the catheter. It helps shield the urethra in the first 15 millimeters of the distal urethra, and allows for the catheter to be gripped from any part. Some Vaporo products also feature a collection bag, which can be especially practical for traveling. The urine can be collected in a collection bag and emptied. Another hydrophilic intermittent catheter that we have is specifically designed for females. And this catheter, the Infina sheet catheter, was designed from input from clinicians to help provide a high level of discretion for women who use catheters. And and actually some of your input, Corey, was instrumental in helping create this product. So I'm very proud to talk about Infina Chic. The catheter is easy to use. It features a catheter case that can be easily opened and closed with one hand, and it's got just the right catheter stiffness to facilitate touch-free insertion. The catheter length helps give confidence that the bladder can be fully drained, and it does not leak when the container is closed. So a person, a female in a situation where they would like to dispose of the catheter may be put back into the case and closed and then disposed of after. So that is a hydrophilic intermittent catheter designed for females. I'd like to thank Best Buy for this opportunity, but above and beyond, thank Corey Knott for such an outstanding presentation. And I'd like to thank all of the attendees for joining us today. If you have any questions about any of our product and services, please reach out to your Hollister representative or our customer support line at 1-800-263-7400. Our customer service department can also be reached by email, and you may also consult the website for further information. So thank you so much, and I'll pass it back to you, Sophie.
Yes, thank you very much. Thank you, Corey. I have a question for you, Corey, because I see that you're in the hospital right now. So we'd like to know what kind of strange, cases you have in terms of reusing the catheter. Can you just explain us what are the common reasons, what do people do, what they shouldn't do? If you can.
Right. Okay, so yeah, I work in a outpatient clinic at Richmond Hospital. I'm on my lunch actually, and so we have lots of different types of patients that come into clinic for teaching of intermittent catheterization. One of our urologists is specialty is in complex urethroplasty repairs. So we do see a lot of patients coming in with scarring or stricturing. So I do a lot of self-cath teaching for those patients to stabilize their scar. We do have some patients with neurological disease, spinal cord injury, MS. Typically, though, the patients that I see are mostly ambulatory. There is a center of excellence at VGH where the patients who have suffered a spinal cord injury will go to that center. Trying to teach self-catheterization, the patients are always very nervous, they're apprehensive, but I sit with them. We provide lots of time with the patient. We show them different kinds of catheter, what's going to suit their needs. We talk about catheter coverage. Do you have third-party medical insurance? Are you covered under a plan within Canada? And so then we're trying to ensure that they can keep a good compliance of catheterization, and that the catheterization is going to be helpful for their quality of life. Usually I spend about 90 minutes with people, and I always follow up with people a week after, and then I follow up with them throughout the year to ensure that they are compliant with their catheterization.
Okay, good, thank you. And concerning the reuse of the catheter, do you have any stats? I mean, is it like 1 person on 2, on 3? Do you have some information?
It's really hard. We do not recommend reuse. And a lot of people have coverage, which is lucky, like a third-party medical insurance. And there are lots of different catheters they can use. And so, you know, if someone is reusing a catheter, there is no way or standardized practice to clean the catheter. We do not have a solution. We do not have a way to sterilize them. And so we really can't recommend that a person reuse their catheter. The catheter can start to crack within one, get micro cracks in the catheter after use. And so we don't want to encourage multi-use of the catheter.
Okay, cool. And we have a question in the chat. So in your experience, what is the most common mistake clinicians make when they implementing intermittent catheterization, and how can it be avoided in practice?
Biggest mistake, I think, not spending enough time with the patient, and also what is their willingness to learn. A patient comes in, you're asking them to start to initiate catheterization. It can be very overwhelming. It can be scary. And so taking the time with the person, the patient, sometimes it requires a few appointments. First of all, sometimes we just talk about the catheterization. And then I say, okay, let's have you come back in 2 weeks, or I'll call you in 2 weeks, and providing support so that the person does not feel like when they're catheterizing that they're on their own and there's no follow-up or support for them. I am quite lucky. I would say almost 100% compliance rate. But we're also making sure that the patient is willing to catheterize and that we set them up for success. We provide printed materials. I email the patients. I follow up with phone calls. They know that they can call me or email me at any time, and then they feel supported in their the process of catheterization.
Okay, so everything is in support, right?
Everything
This is the secret. Yes.
Yeah.
Thank you.
We have some new question in the chat, Corey. If someone is experiencing frequent UTIs, should they stop intermittent catheterization?
No. So they need to be treated for their infection. So they would need a positive urine culture first, and then they would be prescribed antibiotics to treat the infection. If they stop catheterizing and they have an elevated residual of urine in their bladder, that can only help harbor the bacteria. And so they really do need to cycle their bladder and empty the bladder of the urine. And so we recommend that they continually catheterize on a schedule, drink adequate fluid, so they're flushing their bladder out, and we want them just to keep on their schedule.
We have another question for you. So it's pretty long, but hear me out. Our company is required to have a product in each category available to the client that is covered under AADL, max pricing. The new increases in pricing has made this almost impossible for smaller companies to do so without taking a major hit. Is there a resource that's available to these companies that gives a list of products that are still under benchmark pricing?
Good question. To my knowledge, there is no list of catheters that would be fitting in their price range. But I think if you can go to a preferred vendor, they can give you pricing that fits within the needs. There may be times that the patient has to use an uncoated catheter to fit within the parameters of what's allotted each day or each month. It's my hope that Canada will become like countries like the Netherlands or Germany, where you can use any catheter, because really that's in the best interest of the patients, both their quality of life and their bladder, renal, urethral health.
Yeah, thanks so much, Corey. And the Alberta Aids to Daily Living program, there's quite a bit of information within that program. Generally, it may not be required to have a product in each category. I encourage you, if anyone has any specific questions to this program, please reach out to us, because we do have a representation in Alberta and account management in Alberta that can answer these specific questions. They're excellent questions.
Cool. Anthony, do you have more questions in the chat? Or?
No. No. No more question.
Cool. So I think that's it. Thank you very much. It was super interesting. And this webinar was recorded. So we will put the link after on our social media, and you will receive a copy of the webinar or an access to see it. Again, thank you very much.
Thank you, everyone.
Thank you. Have a great day.
Bye.
Bye-bye.
Bye.